welcome everybody to Health or Consequences. This is Commonwealth Magazine and Mass Inc.'s Healthcare Policy Podcast from Massachusetts. My name's John McDonough. I'm from the Harvard Chan School of Public Health in Boston, and I'm joined by my partner and co-host, Paul Hattis, formerly of the Tufts University School of Medicine. Welcome, Paul. Good to see you.
Hi, John.
Even though the world can't see us, I can see you. And I can see our guest, David Seltz. Welcome, David. David
Hello.
is the first executive director and the only executive director of the Massachusetts Health Policy Commission. HPC is the first in the nation independent state government agency charged with bending the healthcare cost curve and providing data-driven policy recommendations regarding healthcare delivery and payment reform in Massachusetts. It is a star agency that other states are now looking at all over the country. How can we get one of those? So it's exciting to talk to David. Prior to this role, David was special advisor on healthcare for Governor Deval Patrick, and before that, for then Senate President Therese Murray. He advised on passage of the historic Massachusetts health reform law in 2006, and he was central to the landmark cost containment legislation, which passed in 2012 and created the Health Policy Commission. David is a graduate of Boston College, originally from Minnesota. He received Modern Healthcare's 2015 Up and Comer Award. I guess you're not up and coming anymore now, 5 years later, which recognizes young executives making significant contributions to the areas of healthcare administration, management, and policy. So David, thanks for joining us today. We really appreciate it. We've been trying to get you on for a while, and we're really thrilled to have you, so welcome.
Thank you. Yeah, John and Paul, thank you so much for having me on. Really excited to be able to have this conversation, and thank you to Commonwealth Magazine and Mass Inc. as well. I think, John and Paul, we had originally scheduled this podcast for, I believe, the second week in March.
That's right.
And it was really the world turned upside down. And so happy to be back with you virtually on this podcast and to be able to engage in this conversation. Just really excited for it. Thank you.
So we're thrilled to have you. And so could we just start out, can you just share a little bit about your background and how it was that you came to be the first and only executive director of the Mass Health Policy Commission?
Sure. Yeah, absolutely. So I went to school in Boston College and have lived really in Boston ever since. And Boston, I believe, in Massachusetts is my home. And I got my first job out of college was in health policy as an analyst for the state legislature, working on the healthcare part of the state budget. And I have to always credit Therese Murray, who took a chance on a Minnesota kid who did not know the difference between Medicare or Medicaid, but was willing to learn, and so changed my life in terms of my passion for healthcare policy and state level, improvements in how we advance a reform agenda. So I've been pleased and really honored to be a part of so many different recent reforms, and you mentioned them, John, in the introduction, but really that the Chapter 5, the healthcare reform access law in 2006 was my first time I really got to see the power of coalition building to really make an impactful difference in the lives of people. And what does it take to get legislation passed? And John, you were, of course, such a big part of that effort. But that really changed my career in terms of what I was passionate about. And I think for me is the through line to the Health Policy Commission, because, with that law, we made a promise to the residents of the Commonwealth, a bipartisan promise from, all different stakeholders around ensuring that everyone will have access to affordable healthcare. And the affordability part of that is a challenge and has always been a challenge in Massachusetts and continues to be a challenge. But it's really kind of one of the biggest motivating factors for the establishment of the Health Policy Commission is how can Massachusetts over time really fulfill that promise of having accessible, equitable, and affordable healthcare. And so, when presented with the opportunity to lead this organization at its beginning, and Paul, you were one of the inaugural commissioners of the Health Policy Commission, I saw this great opportunity to continue a tradition and a legacy that makes Massachusetts so special when it comes to healthcare.
Great, thank you. So let's jump way forward to today. And we know that the Health Policy Commission has been spending a significant amount of time trying to understand and get your arms around the impact of the COVID-19 pandemic on the Massachusetts healthcare system. Can you just kind of summarize for us, what have you learned? What has struck you? What is emerging in terms of the short, medium, long-term impact of what we're all still in the middle of right now?
Yeah, this has been obviously, and I think the word unprecedented is probably thrown around, 10 to 15 times a day. But this was truly an unprecedented disruption for everyone, for every organization, but the healthcare system especially. First, just from the Health Policy Commission standpoint, when this all began in March as an agency, we really first said, how can we help the state? How can we help the governor and Secretary Sutters in their response efforts? And like all state agencies, this was an all hands on deck response. And so really proud of our ability to in a very small way, help and assist what I believe to be truly extraordinary leadership of the Secretary and the Governor in the response, and how we could bring our own data and resources to help the healthcare system ensure that it has the right capacity to meet the patient needs during the surge in cases in the spring. And one of the unfortunate but necessary strategies to ensure that patients could be safely treated for COVID and for other emergency needs was the suspension of elective non-emergent services and procedures in person. And that, of course, results in a disruption not only to patient care and to patient access, but to the financial revenues and operations of all different parts of the healthcare system. So what we saw in March and April especially was a significant reduction in the utilization of healthcare services from across all different parts of the system, from hospitals to physician offices to community health centers and dental practices. And I think one of the kind of surprisingly positive impacts, telehealth became a really important tool to fill in that gap for both patient access and for the ability of providers to continue to see patients and be able to receive financial revenue. And so that was, I think, a really crucial emergency order that the governor put forward to have expanded access and coverage and also payment for all different modes of telehealth. And as we see the data, that has been crucial in being able to maintain some of the utilization in areas, especially behavioral health. We've seen a pretty tremendous uptake in the use of telehealth for many different services, but behavioral health being one of them, and as we know, an area of increased demand and importance always, but especially during this particular moment in time. So what we've seen now is we're starting to see care returning to those inpatient settings. We're starting to see utilization begin to return to some baseline levels with the combination of telehealth there. But it's been slow. And I think Massachusetts, by many data points, has been, in some cases, slower to recover than other states. We were hit harder than many other states at the very beginning of this epidemic. And, areas of concern that we're tracking, we still are seeing pediatric visits that are below baseline. And so we need to see how utilization and how people's use of care in different settings returns. But it's fair to say that all parts of the system have been impacted, and the fallout will be extensive over the next year and probably longer, obviously not knowing when a vaccine will occur.
David, let me add my words of welcome, and I can say as an inaugural commissioner, the most contributing and impactful vote I ever took was to make you, along with others, voting to make you our executive director. So I'm happy we did that, and I'm also happy I'm sitting here today with you. Let me ask you something that builds a little bit off your summary about what's happened in this era during COVID by getting into it this way. If anybody knows anything about the Health Policy Commission in our state, it's tied to the concept of something called it's oversight or support of the market and system to live under what's called the state cost growth benchmark, or sort of a spending growth per person limit that was established back in 2012. For our podcast listeners, can you say first a few words up through before pre-COVID, up through the end of 2019, how we've been doing more or less against that benchmark? But I wonder if also too you would comment about, as you just noted, the reduction in total spending, what the implication might be for the 2020 benchmark when you're sitting down, let's say late next year, looking at it, and then beyond. So thoughts about all of that, if you would.
Yeah, absolutely. So the healthcare cost growth benchmark is a central organizing principle of our state's efforts to try and reduce the growth in healthcare spending to a more sustainable level year over year. So it is a target that is set by the Health Policy Commission, most recently set at a 3.1% growth. And I always want to emphasize that we are still talking about a growing healthcare system and growing spending, but with growth that is more in line with how everything else in the economy is growing. That is the theory, of course, and now we are in a moment of disruption, both of our economic situation, but also in terms of what we can expect for healthcare spending. But before COVID, we have measured our performance against the benchmark for 6 years, and the data indicates that we, I mean Massachusetts, have had experienced some notable success in reducing the growth in healthcare spending. In 4 out of the 6 years, the state's growth in healthcare spending was below the benchmark that was set. And on average, across the 6 years, we've been below the benchmark. And I think more importantly is our comparison to the US trends. What we've seen is that since 2012, our healthcare spending growth has been below comparable US rates every single year for the past 8 years. And that is a significant reversal from the prior trend. If you look throughout the 2000s, healthcare spending and healthcare costs were growing much faster here in Massachusetts than the rest of the country. So we do see a reversal in trends that I think speaks to not only the benchmark, but around the entire culture that wraps around the benchmark in terms of emphasis on affordability and cost savings. And when, just as an example, when you think about the benchmark, it is a long-term strategy. I like to think about it sometimes like a mortgage. If you can shave a percent point or two off of your interest or your annual rate on your mortgage, it may not save you a ton in 1 year, but that starts to compound and compound and compound, and pretty soon you're talking about real money, and that's what we've seen. If you compare just in the kind of the employer-sponsored health insurance space, so kind of private health insurance, our growth rate has been below the national average every year, as I mentioned. And if you added up all of the money that we would have spent if we had been at the U.S. growth rate, you would get to $7.2 billion more in healthcare spending that Massachusetts would have spent over the last couple of years.
It's a lot of money.
This is money that would otherwise have been a burden on small businesses, on residents, on consumers, and on families. And I know it's hard to kind of quantify that because you're talking about an avoided potential expense. But that's just to show that if you can bend this cost curve even a percent or two, you can really start to have a pretty big impact in terms of the resources that can be freed up for all of those important stakeholders. But the last point I'll make on this, Paul, is, and John, is that even with that moderation in recent years, let's be clear. Healthcare is still very expensive in Massachusetts. By any measure, we are among the most expensive states in the country. Over $20,000 a year is the average cost of a family health insurance plan. That's basically the cost of a Ford Focus every single year. So it is important to remember that this is a long-term strategy that is important for the affordability of care.
And
now,
COVID, tell us about COVID and its impact for the benchmark for this year and your guys' work.
So thank you, Paul. And COVID will, we know, have a big impact on healthcare spending in 2020. I can foresee a scenario, and I'm not, I don't have a crystal ball, but I could see us having a negative number in terms of 2020 as a result of that significant disruption in utilization during the spring, and kind of a slow return to that care. So when we're examining how Massachusetts performs against the benchmark next year and the year after, we're going to have to take into account and try to understand how COVID really played into this. And I think that's an important point for thinking about the benchmark. The benchmark isn't, we don't live or die about whether we're below or above the benchmark. In some ways, the benchmark is a tool for being able to understand in a very data-driven way what is driving healthcare spending, where are those opportunities, and to be able to have a platform to do a deep dive. So I think that we will see, probably below benchmark spending in 2020. We could see greater spending in 2021, given the return to care, potential vaccination. So as we do all of our work, it's really about putting the data into the context of the reality, but then using that data and that platform to surface those areas where we want to prioritize our policymaking efforts to continue the long-term plan of keeping healthcare cost growth down.
David, in addition to COVID this year, issues of racial and social injustice have been at the forefront of all of our thinking. And the commission recently decided to make that a focus for part of its work here. What have you learned so far, and where might some of this work take you?
This is really important, and I'm really proud of the work that we have done so far this summer, but there is a lot of work to be done. The disproportionate impact of COVID-19 on Black, Indigenous people and people of color, I think, combined with the national reckoning on police violence and murder, has appropriately and belatedly led to a lot of reflection from everyone on the historical role of racism throughout society, but in our world, in healthcare and in health outcomes. And as a healthcare organization, we felt it was important not to just have a moment of reflection, but a commitment to action. And so we, as you noted, Paul, advanced a new framework, a commitment to making equity a core part of our work and mission moving forward. We brought that forward to our board in July. We edited and changed our mission statement to make clear that equity and equitable is central to what we are trying to promote in our healthcare system, and that the success of our efforts to have a high-performing healthcare system is contingent on it being high-performing and accessible for everyone, not just certain populations. And so, with that commitment and that public statement, it's about getting to work, and how do you change the work to reflect that commitment? So we are going through a process of evaluating every project every program, every data asset that the Health Policy Commission administers and has access to, and reconceiving of it and challenging ourselves to say, how does this fit within the broader conversation around advancing equity? And as I said, challenging ourselves to change and pivot and adapt. And, you know, as an example of that kind of challenging, data is a huge part of this story, especially in healthcare. And when we don't have the right data to even allow us to understand the disparities in how people experience and interact with the healthcare system, we're not going to be able to truly understand both the drivers of it and the solutions to it. And I think, unfortunately, there's been too much of a willingness sometimes to say, okay, well, if that data set doesn't have race and ethnicity data in it, okay, that's fine. We'll just move forward and we'll do the R analyses on some of these other variables. And I think the question now is, well, why isn't that data included? And what can we do along with our sister agencies to and the marketplace to say, how do we build the right types of data and programs and commitment, and not just accept some of the limitations that hinder our ability to make equity a central part of our work.
Okay, shifting gears just a little bit, and we're always steering close to COVID-19 because it is so pervasive in its impacts. So we know that some of the biggest beneficiaries financially from this crisis have been the health insurance companies nationally. In Massachusetts, we recently learned that insurers have received approvals for 8% average increase in premiums for renewals starting this January. Is there something we're missing here? If they're doing so well financially, why are we seeing this significant increases, and what impact will this have? Do you have any thoughts about that?
I think, the numbers are troubling. Seeing, an average of 8%, seeing some plans with double-digit premium increases raises a lot of questions, for you and for the public, because we know that there will be windfalls, financial windfalls for many health plans in the current fiscal year due to the dynamics that we've already been talking about. And I understand that health plans may be conservative in their analysis of what may happen next year, and that they are doing an analysis of what they expect healthcare spending to be in 2021, not 2020. And I understand that there are mechanisms to potentially share those excess, windfalls with consumers at some point through rebates. But the reality is none of that will help residents who are trying to afford health insurance on January 1st and seeing a significant increase, or a small business that's trying to sign up for health insurance and trying to hold on to their ability to maintain health insurance for their employees. So, I think there are important questions that still need to be raised here. I have all the confidence in the Division of Insurance that oversees this process for their role in reviewing rates in a portion of the market. But I still hope that the health plans understand that perhaps now is not the time to be overly conservative in these estimates when so many providers, patients, families, and businesses are struggling. And so this is a topic we will certainly be focused on moving forward into next year, and to try to understand the intersection between decreases in healthcare spending in 2020 and increases in premiums in 2021. I think that's very, it's a hard story to tell to the public, and rightfully so.
Well, David, maybe you'll have even a little bit more opportunity, at least you and the commissioners, later this month, because this is October and it's cost trends hearing month in HPC world. And while you won't be at Suffolk Law School, you'll be online. There'll still be a lot of people. I'm certainly, John and I will be two of them, tuning in. on the internet. So what should we expect to learn this year? And what will we hear about at this year's hearings?
So every year, the Health Policy Commission hosts an annual summit on healthcare costs, healthcare spending, healthcare topics. We call it our annual cost trends hearings. Usually an in-person 2-day affair with many speakers and panels. So this year we are doing things a little bit differently, as you might imagine, Paul and John. We're doing a virtual event. It's on October 20th. You can find information about it on our website. And we're going to have a more focused event this year with a half-day event, really talking about all of the issues and questions that you have been raising with me today. The impact of COVID on our healthcare system, assessing equity and how we have a more equitable healthcare system moving forward, and the disproportionate impact of COVID on communities of color. And so we're really pleased that we'll have a great speaker, Dr. David Williams, a internationally known social scientist and expert on social influences. Governor Baker will be providing some remarks as well. And we'll have really 2 panels with new perspectives and new voices about how their organizations or how they themselves felt the impact of COVID. And not just to have, in addition to, I think, a necessary reflection, also a conversation about the future. How do we build a more resilient and healthcare system, an innovative healthcare system on the other side of this pandemic? And how can we take some of the incredible lessons learned, both good and ill, from this experience and use them to strengthen and build a better healthcare system? I think of things like telehealth, and I am heartened by the promise of being able to use technology in new ways to extend access to care. I was heartened by the use of different types of workforce that became so important in delivering care. And how can we take those lessons learned and apply them to the future will be, I think, a big part of the conversation at the cost trends hearings this year.
David, one thing I haven't heard you say, at least so far, but has been often a conversation at the cost trends hearings and at HPC board meetings, is the issue of hospital payment rates, which often on the commercial side vary significantly based on market size and power. We haven't heard a lot of discussion about that issue lately. Is it gone for good, or only a little bit more of a back burner because of COVID right now? Your thoughts about that?
The underlying variation in payment rates for hospitals, as you know, Paul, is very clear from the academic literature, is not necessarily correlated with the quality of care that's being delivered or even the complexity of care. It is most tightly correlated with the market leverage and the size of those organizations. And that has created an imbalance in not just the Massachusetts healthcare system. This is a US healthcare system dynamic with the private market negotiating power of providers and health plans. And so this issue has not gone away. We have, I think it's fair to say, not seen any significant reduction in that variation over the last 8 years since the benchmark was put into place. It does not appear to be an issue that fixes itself, and yet policy solutions are difficult to find consensus on. As you might imagine, this topic exposes divisions within the hospital community, and divisions within policymakers about what is the best and right approach and role for government interacting with the market to try to better align higher payment with higher indices of value. And so I don't think this is off of our radar for very long, Paul, because as we move forward, I can hypothesize a scenario where many of the hospitals and biggest health systems may seek to recoup, understandably, their financial losses from COVID through negotiating higher payment rates. And will those precious dollars go to the biggest systems, or will they go to the smaller hospitals? will we actually see a greater divergence in some of these payment rates moving forward when the pressure is on and the pie is only getting smaller? So I think this is a topic we continue need to have a lot of vigilance around.
I'm glad to see you're going to have a lot of vigilance on that topic. You know, last year's cost trends hearings, you had a whole panel on the issue of waste in the healthcare system. And coming out of that discussion was a desire, I know, from a lot of the commissioners to take on issues of waste. How's that going? And what have you learned this last year?
So we identified, and by waste, I think what you're referring to and what we were working on was really some of the kind of administrative side of healthcare, of our US healthcare system, that provide a tremendous amount of burden and don't appear to provide very much value. Think of things like all of the Byzantine bill claims processing rules and prior authorization rules and utilization controls, all of which, came from probably a rational reason to be implemented, but over time have been layered and layered on top of each other, and requirements for providers and for patients. It's so incredibly confusing and so incredibly burdensome. And at the same time, it adds more costs into the healthcare system. So we said, let's try to understand where some of these areas are and see if we can at least begin a conversation about how to have a more rational way of actually administering healthcare that benefits providers, that doesn't burn them out, that still has proper controls and oversight where necessary, and makes it easier for patients to navigate this system. And what we saw is that there's just a tremendous amount of variation about how different health plans apply some of these different types of tools. And I'll just give a very brief example. We looked at a small set of 26 orthopedic procedures, and we looked at all of the prior authorization rules for 8 different health plans for those sets of procedures. And there was not a single procedure of all 26 where that was either consistently required or a prior authorization was consistently exempted. And in fact, there was absolutely no consistency across the 8 health plans and what their requirements were for these set of procedures that everyone could probably know and understand. And so if you're a provider trying to navigate this system, you have 8 different sets of rules, depending on what insurance card that patient has in their pocket. And that doesn't seem to be providing very much value on a system-wide basis. And I'm sure each health plan and would probably say they've designed their best version of this program. But when you take it all into account, there's got to be a better way to do some of these things. And we're talking about billions of dollars of just added expense that isn't being used for patient care in a way that we think provides value. This is an ongoing conversation and priority for the Health Policy Commission. I will be honest, the COVID impact makes this a challenging conversation in some ways because everyone is stretched so thin in terms of the demands on their operations, and people have made absolutely extraordinary accommodations, and I want to here credit the health plans for many of the accommodations that they've made. But this is an area that is a perennial issue and one that I think Massachusetts can lead on in ways that bring people to the table together and find common solutions. It's not about picking on one side or the other, but really about putting the patient at the center and saying, how do we build a system that's going to work best for that patient?
So, David, one of the hot topics that you've been pulled into by the legislature is the issue of rising costs of prescription drugs. And you were directed by the legislature to engage with the drug companies, start a conversation, public and private. What are you learning? What is going on? How is this unfolding as you get deeper into it?
So prescription drug spending has been one of the key drivers of healthcare spending in the last few years. We've seen increases above benchmark spending for a few years in a row now. And so the governor and the legislature came together on a pretty innovative new state solution that has at its core both the MassHealth, the Medicaid program, looking at certain high-cost drugs and being able to negotiate directly with drug manufacturers on potential financial relief for those in the form of rebates. And if those negotiations fail, MassHealth has the opportunity to actually refer a drug to the Health Policy Commission, so the Health Policy Commission can do an objective assessment of the value of that drug and the pricing of that drug in relation to that value. So this is new ground for the HPC in terms of understanding how value assessments are conducted both by many different organizations in the United States and across the country. And while we have not yet received a referral of a pharmaceutical drug from us, we've been using this time since that law passed to really educate ourselves as a staff, as a board, on this important part of the market about how pricing works and wholesale costs work, and a whole new set of acronyms, and also to really engage deeply with the broader stakeholder community, including the drug manufacturers, to understand how they view this process. Talking to patient groups, really important to have patient voices at the table whenever we're talking about the value of drugs and what that means, and also clinicians, of course. So we're really trying to build a transparent process that can have the confidence of many different stakeholders when that time comes for us to do an objective review. As we know that these may be controversial, and this is new ground for Massachusetts. So a lot of behind the scenes work, a lot of work with the broader community to make sure that we're prepared to do our part to the standard of the HPC when that time comes.
David, beyond the benchmark, if the HPC is known for anything, it includes its review of proposed major market transactions that could have cost growth implications. And in late 2014, the HPC's review ultimately was instrumental. Findings that led a local judge to reject that purchase by then Partners Healthcare of South Shore Hospital to go forward, saying it was not in the public's interest because of cost growth. You guys did a very detailed analysis of the proposed Beth Israel Lahey merger, and ultimately Attorney General used those findings to craft an agreement that allowed that transaction to go forward, but put in place a number of different conditions tied to the concerns that you identified. We're sitting now waiting for word on Harvard Pilgrim and Tufts Health Plan coming together, something not in your jurisdiction to review. That's really for the DOI. But if you read the literature these days, there's a lot of talk nationally about, in this COVID era, are we now about to see another onslaught of healthcare system proposed mergers and consolidations, resulting in part because some actors or providers, I say, are stronger and some are weaker. But what are your general thoughts about what might happen there, particularly in Massachusetts?
Yeah, I think it's always difficult to predict the future here, but the signs indicate that we can expect more consolidation. Certainly that was the trend before COVID. There has been a slight a pause in some of those mergers and acquisitions over the last 6 months as organizations have rightly focused on the care of COVID patients. But this was such a disruptive event with long-standing implications that I think it is fair to predict that we will see even more consolidation, new relationships between providers, the continued shift away from independent physicians to employed physicians who are part of bigger health systems. Quickly on that note, we did a survey of physicians in Massachusetts in the summertime and found that physicians were reporting significant financial distress due to the disruption, and indicated a much greater interest in either merging with other physicians or being consolidated into a major physician system or hospital system. So we are already preparing and thinking about what those types of transactions may be. and how we might adapt and change our review processes in light of COVID and in light of what the goals of these transactions may be in a kind of a whatever we're calling this part of the COVID time period. So we will be keeping our watchdog eyes closely attuned to all of those dynamics.
So David, our final question, and thanks for staying with us for so long. We only got to about half the things we'd like to talk to you about, but this is terrific. So interesting, 2006 Universal Healthcare Law in Massachusetts became the model nationally, embedded into the Affordable Care Act, and the 2012 law that created the Mass Health Policy Commission. States all around the country right now are looking at your model. Delaware and Connecticut have set up their own versions of the MHPC model. Other states like Colorado and Pennsylvania are looking. I learned that the National Academy for State Health Policy is recommending your model to states all over the country. How do you view the success of this model, and what does it say to you about maybe not just Massachusetts, but what's happening around the country right now?
So one, it's not my model. This is our model. This is the Massachusetts model, and I think other states are always looking to Massachusetts when it comes to healthcare policy, and I think this is another, as you mentioned, in a line of truly remarkable innovations dating back decades, of which, John, you were a part of many of them. I think what's interesting nationally is that we were kind of ahead of this cycle in some ways. We tackled the access part of this and had so much tremendous success in 2006. And for many states, other states, they really began that journey in 2010 after the passage of the Affordable Care Act. And in some cases went through multiple years of disruption to the individual markets and stabilization. And I think more recently have come to this same fundamental and underlying challenge, which is the underlying high cost of healthcare. And what can we do that to bend that cost curve? And so, pleased to see so many other states be able to learn from our lessons learned and challenges faced. We think of this as being a part of an ecosystem of states that help and learn from each other and the innovations in many of those other states. But I do want to give absolute credit to be humble about our ability to share those lessons learned, but also to be proud of the success we've had. And that success to me is really driven by our absolutely tremendous board of commissioners who lead the work of the agency, all incredibly nationally recognized leaders. Thank you, Paul, for your service on the commission, and for the staff of the Health Policy Commission, who are the most brilliant, smartest, most passionate public servants that I have ever worked with. And so it is through the board, the staff, and the commitment to excellence and adaptation that I think is often at the core of our success here in Massachusetts. And finally, with the community at large. This is not just government. This is about how government works together with healthcare to improve healthcare for everyone.
The longest podcast we've done, but for those who have sat through this with you, David Seltz, Executive Director of the Health Policy Commission, what an incredible, rich, and thorough understanding you've given our folks. And I know there's more to come at the HPC cost trends hearings later this month and beyond. So thank you so much.
Thanks, Paul.
Thanks, David.
Thanks, John.